There's a great deal of concern and unrest in the field of allergy. There's concern about reimbursement, about changing in reimbursement patterns. There are just huge changes coming in the way we take care of patients in terms of new therapeutic modalities that are becoming available and which of course are going to be very expensive, which again raises concern that we're going to have difficulty with reimbursement for not just for our pay, but for getting reimbursed for medications that we need to use. So that the unrest that is in American medicine as a whole is really has impacted the allergist immunologist. The core is we still have a group of patients who need to be taken care of. We still have a great group of folks that provide very good care for patients. It's a little different in terms of allergy and immunology. We don't have an organ system. We don't have we're not pulmonologists who say everything lung is ours, or the gastroenterologist who has everything GI tract. But we have a group of diseases that are around an allergic diathesis. And so we're involved with the upper airway, we're involved with the lower airway, we're involved with GI diseases, with food allergy, we're involved with the skin, with urticaria, with contact dermatitis. And so there is some concern that because different groups are working with the same patients we are, that there's concern about potentially losing our patients to some of these other groups. On the other hand, when you look at the fact that allergies are increasing in America, the other side of that same coin is there's concern we won't have enough allergists. And the fact that as we see food allergy increasing, we see asthma increasing, across the board our allergic conditions are becoming more frequent, more common. And so the other side of that concern is potentially we won't be able to care for all the people who need us. We go back to the patient. I mean, this patient-centered care is where everything has to begin and is where we have to put our absolute focus. And so part of what we're doing is learning better to work with physician extenders, with our nurse practitioners, with our PAs. And that's a very important part in some practices and in some areas of extending our reach and extending our expertise. Certainly providing additional education across the board to all groups is an important part of what we do. The biological drugs or the biological agents have really changed medicine, and yes, they're very expensive, but they're incredibly expensive to do the research, to do the development that is required to put those biologicals on the market. There will be increased competition as more and more of the biological agents come into the system. Hopefully we'll be able to learn how to manufacture biologicals with a less expensive rate. But this is a new classification of drugs, and unfortunately it's a new norm that we've always had tiered drugs. These drugs are relatively inexpensive and they work pretty well. These drugs cost more and they work in some cases a little bit better. What we're going to have to really figure out is how do we determine which patient needs which of these expensive drugs so that we target our therapy in a more appropriate way. That's where the real secret is. And in some ways that's where the money saving is going to come, because we're using the most appropriate drug for the most appropriate patient without simply using trial and error to determine which drug is the best.